Welcome to the Hospital Finance Podcast, your go-to source for information and insights that can help you protect and enhance revenue at your hospital. And now, the host of the Hospital Finance Podcast, Michael Passanante.
Hi, this is Mike Passanante, and welcome back to the Hospital Finance Podcast. Today, I'm joined by Alan Coppock, who is a seasoned healthcare and hospital leader, author, husband, father of 7, and grandfather to 2 baby girls. He's helped to start hospitals in Kentucky and connected other hospitals to solutions that put them on a more solid footing for sustainability. In mid-2017, Alan stepped out of his CEO role at the hospital he founded in order to start a new company, Adminologybay. From this platform, he offers a range of consulting services focused on operational efficiency, culture, and people, and his team has launched 2 online membership communities, ProviderBay.com for licensed healthcare providers, and Execubay.com for senior healthcare leaders. And now he's also a podcaster, having just released the first episode of the Caring for Healthcare podcast. And Alan has joined us to talk about his experiences as a healthcare leader and to share his thoughts on improving the operational efficiency of healthcare organizations. Alan, welcome to the podcast.
Michael, thank you, and I am thrilled to be part of your podcast.
Well, it's great to have someone of your caliber on the podcast. And let me just start out by asking you, how did you get started as a healthcare executive?
Great. I'll be as brief as I can. In 1994, I had my first healthcare job. I stepped out of the higher education career track that I had been on for about 7 years. After I graduated from college, I worked for the college where I attended, University of the Cumberlands in Williamsburg, Kentucky, and worked for them for 7 years. I had the great honor and privilege of working for one of the premier small college hospital presidents, Dr. Jim Taylor, for those 7 years, and learned just a tremendous amount about organizations and management and about fundraising. Dr. Taylor has the legacy of raising well over $100 million for this small, beautiful little university in the hills of southeastern Kentucky. So for 7 years, I just learned a lot and stepped away from that in 1994 to my first healthcare job in the home health space, and did finance and accounting and payroll and all of the financial functions and some IT stuff, because my background from a degree standpoint in college was in the information technology space. So I helped this company put their first network in and connect offices. We had about 250 employees and 5 locations, and so we connected all of those. Learned a lot through that as well. In 1998, I had my first hospital job as a VP for the ancillary departments in a 270-bed regional medical center in rural Kentucky, and that was a great experience. Spent 6 years supporting the executive team, and in 2004, had the opportunity to start my own hospital within the walls of the bigger hospital. It's a special designation called LTAC, or Long-Term Acute Care Hospital. Is the Medicare designation for hospitals that take very sick and multiple comorbidity patients. So in 2004, started that, led that hospital for 13 years. In the process, helped to found a couple of additional LTACs in Kentucky, helped to found a federally qualified health center, or FQHC. It's a primary care focus for southeastern Kentucky and medically underserved rural areas of our state. So I've had a full career already in healthcare, and just been blessed to do some really incredible things, build teams and hire folks and develop policies and meet all the regulatory requirements, which are, as you know, are myriad. And so that's kind of where I got to in 2017, when I stepped out of that even and started Adminologybay.com, my consulting site, to support healthcare leaders and fighters in navigating all of the changes that are coming our way.
Indeed. And I've heard that you like to teach in metaphors. Can you give me your favorite metaphor when it comes to the operation of a successful hospital or healthcare organization?
Absolutely, Michael. So let me set up the scenario. Our frontline staff are working harder. They're covering more territory. Their patients are more numerous and they're sicker. That's the nature of the hospital inpatient business today. Is patients don't get admitted to the hospital until they are very sick. And so the nursing staff has felt the pressure of that. They also have less support from the nursing aides, from the pharmacy, support departments, environmental service, and food service. There's just fewer resources to support the nurses at the bedside. And they're also expected to be more flexible and willing to work in more than one area or unit. For years, nurses could pretty much find the unit or a particular type, whether it be a med-surg, telemetry, ICU, emergency room. They could find that area that fit them, even mothers and babies, and labor and delivery in that space. So nurses were generally able to pick the area that fit them the best, and that's not so much the case anymore because teams have to be more lean. There's a built-in expectation that there be more flexibility, and that's tough. So as a leader, as a senior leader, I had to help my team through that transition, and so I wrote a blog post called Revenue Minus Margin Equals Expense. It's a backwards way of thinking from what we've traditionally thought as hospital leaders and even finance people. We've thought, well, my operating equation should be revenue minus expense gives me my margin. And what I've proposed in my blog post is that no, if we're really going to be successful, we've got to accept the fact that the equation is shifted, and so revenue minus my margin, what's my target, gives me the expense load that I have, and that's what I get to deploy to meet the needs of our patients, to get the best outcome, and most often that means we're going to see an expense reduction. So we have to understand that. We have to have our eyes open. If our organizations are going to be sustainable, we've got to generate a margin. So in order to describe all of that, I came up with what I call the MLB metaphor, Major League Baseball metaphor. My wife and I are huge Cincinnati Reds fans, and I know that's not real popular now because the Reds haven't performed great this year at all. But my MLB metaphor simply says this: when the coaches prior to a Major League Baseball game come to the home plate to meet the umpires, and the team's head coaches are there at home plate standing with the umpires, we've seen it. We've been to games. We've seen it on television even. The camera always gets a shot of this. They're having a discussion. And my wife and I used to joke and say, I wonder what they're talking about, because everybody knows the rules, right? And so,
right.
But one thing that I know that they're not talking about is I can almost assuredly bet that the umpires are not asking the coaches, how many players would you like to have on the field today, coach? I'm pretty sure that's not one of the questions being asked, because in fact they know that each team can field no more than 9 players at a time. And it's how they position those players, and it's the strategy that they deploy, whether or not they shift their infield to the right or to the left, or their outfielders in or out based on the hitting statistics of the next batter. That is the strategy is what most often will determine the outcome of the game. So it's not a question of how many. And I think that's where healthcare leaders have figured out that they've got to accept a new reality, and that is we only have a certain or a finite amount of resources to deploy, and we have to figure out, based on our strategy and how we deploy those resources, how we're going to cover all of the needs that are required by our patients. And and by our physicians. But it's a reality, I think, that that healthcare organizations are grappling with, and those that accept that reality and deploy appropriately those resources, I believe, are going to be the ones that find themselves on a more stable footing, a more sustainable path, and I think that's pretty critical from a foundational standpoint.
And certainly you've seen your share of changes throughout your career. How have you seen the hospital finance function change throughout your career, and what are some of the biggest challenges facing hospital finance departments in your opinion?
That's an excellent question, Michael. Back in 1998, one of my first sit-downs with the CFO of our organization, when I was a VP of the support departments, just wanting to do the best I could to lead those departments. I sat down with the CFO, and he was particularly frustrated. And he said, I want you to know that my job is to be your scorekeeper. I will bring you the results, and you have to manage them. And I caught on to the fact that he was quite frustrated, so I said, well, why are you frustrated? And he said, well, I just feel like I'm being expected to do much more than really is in the scope of what I'm supposed to do. I'm supposed to give you your results, and then you act on them. And instead, I have to figure out how to solve some of the deficiencies, or some of the ways that we're not achieving the results that we are supposed to achieve. Well, here's where I think a big change has happened. I think that hospitals and healthcare organizations are figuring out that they really need a strong operations focus, and whether that is the CEO, who is ultimately the operator, and brings that focus, that level of focus on operations. When I talk about operations, I do a lot of mentoring of future leaders, and so I always ask them, what is in your MHA program? What are they teaching you about hospital operations? And most often they say, well, we know the term, but they really don't talk a lot about operations in the program. And so I give them just a quick lesson in operations, and I say, the hospital operator is that person who, if you could picture a wall full of dials and meters, the meters are the indicators, the measurements that the organization feel are key to their success, those metrics that they are measuring daily, weekly, monthly, quarterly, etc. And then the dials are those initiatives that we can put into place that impact or affect those measures. And the operator is that person who is in front of the dials and meters, making adjustments, understanding that an adjustment to a productivity dial, for instance, may impact other measures or meters, and so from a finance standpoint and the change over time, I believe healthcare organizations are maturing to the point they understand how important it is to have an operations focus, and it takes a lot of pressure off of finance, so that finance can then truly become what my friend, the CFO, back in 1998 was frustrated about, wanting to simply be the scorekeeper. Yes, offer input into the strategy, but not be expected to solve every problem, because it just wasn't possible for the finance department to have that as their focus too, solving the operations problems. So I think that's the biggest change, just a new focus on operations.
Alan, what ideas do you have for bending the cost curve down for hospitals and other healthcare organizations?
Well, I'm doing a lot of writing about this. I think I know that hospitals and healthcare organizations, providers in general, are being paid more this year than they will ever be paid in the future. I think that we all have accepted that our reimbursements, what we're paid for what we do, is on a downward trend. And so it's incumbent on any strong leader to begin asking the question of what costs do we currently have that we can either reduce or eliminate. And there are a couple huge ones that I've been writing a lot about. The first one is agency staffing. And what this pertains to is the idea that you engage or contract with a firm that would supply nurses when you need them to cover shifts. If your volume peaks and you need additional nurses, you can call the staffing agency and have them supply the nurses. What we know in the hospital world is, there's an upcharge for using agency staffing rather than hiring your staffing, and the upcharge is conservatively, 35 to 40% to engage that agency. And we also know that it's a multi-billion-dollar industry, the agency staffing business, if you will. And so it's a cost that I think can be greatly reduced, and in many cases can be completely eliminated. And the way that happens is that an organization gets very serious about its culture, about being the place that the high performers in the market prefer to work. And when that happens, when there's a vacancy on your staff or on your team, it's much easier to fill. I'm writing an online course right now that's titled How to Become the Magnet in Your Market. And it's basically a recast of the initiatives that we deployed in my place, where when we had a nursing vacancy, for instance, in the summer of 2016, we attracted 63 qualified applicants for one vacancy in a small LTAC, 32-bed long-term acute care hospital. In the spring of 2017, we had another vacancy and attracted 35 applicants. So there were some things that we were doing that I feel like can be valuable to other organizations who decide in a competitive market, maybe there's 2, 3, or even 4 hospitals in a particular geographic market, that one of them decides, well, we're going to become the magnet in our market. And what that will do is greatly reduce my reliance or my need for the very expensive agency staffing solution. So that's one. The second is another multi-billion-dollar healthcare expense that I think can be greatly reduced, if not eliminated in many cases, and that is in the recruitment space. When a hospital or healthcare organization needs a new physician, most often they turn to a recruitment firm, and the firm promises to bring this or to fill or place a physician into that open vacancy. And the fee for this is exorbitant. And it strikes me as odd that healthcare organizations haven't yet embraced the fact that this is a cost they can avoid. So let me give you for instance. A hospital needs a hospitalist. The fee for that, for placing that from a recruitment firm, for placing a physician into that position, could be when all the expenses are paid and all in is about $50,000 for one physician to be placed. And when it's that's a hospitalist, internal medicine or family medicine background. If it's a highly sought-after specialty, cardiology or other, then that fee could be much higher. It extends also to the leadership appointments or leadership recruitment firms that are executive search firms. And in their case, they could charge anywhere from 30 to 50% of the first year's total compensation. So if it's a 6-figure job, and with the incentive in place, year one, whatever that total compensation is year one, take 30 to 50% of that, and that is what would be assessed as a fee for placing that executive by an executive search or an executive recruiter. Those are two costs that I think can be avoided, and you might say, well, how can they be avoided, or how could hospitals avoid using a physician recruiter? And and that's part of what I address in our developing the online membership communities. The Providerbay.com is a place where we hope to introduce paying members to the community, to the opportunities that are available from organizations, and completely what I've always thought is that hospital leaders are plenty smart enough, and physicians are plenty smart enough for sure, that they can decide when the right organization, the right opportunity, the right fit for them, and then the organization, I believe, is capable of putting the opportunity out there, and then essentially attracting physicians. We really don't need the help of a recruiter. As a matter of fact, I have trouble finding the value that recruiters or staffing agencies actually bring to healthcare. And this next 2 to 5 years particularly, Michael, is going to be all about delivering value, lowering cost, improving outcomes, and so we're going to need to be very intentional about who we partner with and whether or not they are delivering value to us as providers in the community.
And Alan, as organizations operate more efficiently, what are some of the impacts on culture? Can you address some of those?
Yes, as I mentioned earlier, I'm developing an online course for organizations titled "How to Become the Magnet in Your Market." This is a very intense cultural focus. It starts first with developing strong managers and strong leaders. Managers, or the manager aspect of a supervisor role, is that technical aspect, the skill to manage policy, to manage expectations, but leadership is the second aspect of that, and that's the idea of being that for a supervisor to become a leader is when a supervisor becomes the person that others want to follow, that is inspirational and that is engaging, that is maybe we talk about servant leadership in a big way. So it's developing the strong managers, strong leaders. That takes a senior leader team focusing on how to make their supervisors rock stars. And for years, I've seen this happen over and over again. Hospitals will promote a star nurse or a star therapist to a leadership role, but then do very little to empower or enable that nurse to be effective by supporting them from a training standpoint on how do you develop those managerial skills, how do you develop that leadership potential that I think all of us have if we're given good guidance. And then from a cultural standpoint, it's recognizing and rewarding high performers. And I believe when you recognize and reward appropriately high performance, that's one of the key elements of being able to attract high performers to your team. And then another aspect is just recognizing that results are what we're graded on. It is not good enough, and I would tell my team this. I would say to our incredible nurses, I would say, listen, it's not good enough anymore for us just to be awesome. The fact that you're awesome is really the first reason that you're here. We brought you into the team because we believed you're awesome, but that's not where we're graded as being great people. Where we're graded is whether we can achieve the results that are needed for our patients, for our organization. And there's a lot of ways. As you know, we're graded now on patient satisfaction. How we either delight or miss delighting our patients. And our patients now score us that way. And payers are paying a lot of attention to how we score regarding patient satisfaction. Outcomes, how we achieve the correct outcomes, how we avoid the events that lead to poor outcomes is a second way. A third way we're graded is on margin. We have margin targets. It's built into our budget. We know, we want our margin, obviously, operations margin to be positive. In many cases, this last cycle, hospitals were not able to achieve positive margins, and therefore are in a state of kind of turning things around because you have to. It's not an option anymore for an organization to generate a negative margin year over year without some attention to turning that around. So margin is another way we're graded. And the fourth one that I focus on is that aspect of value, whether we truly are over time bringing down our cost burden and improving our outcomes. That's the value equation.
So, Alan, you've alluded to a new membership community that you've created for healthcare professionals as well as a podcast. Can you tell us a little bit about those?
Absolutely, Michael. We've launched ProviderBay.com for physicians and physician extenders, nurse practitioners, physician assistants, these licensed healthcare leaders that are leading our clinical teams, that are leading the focus that we have on patients. Here's what I found out, or just from talking to just so many physicians who are frustrated, the pace of change. We've moved from many doctors being independent entrepreneurs in their own right to now looking at employment contracts and agreements. And I've told hospital leaders, even my own hospital board, I've said for a couple of years now, we begin to employ physicians, and then that leads us to treating doctors like employees. And then we wonder and we get frustrated and gloomy when we start recognizing that they begin to act like employees. And I don't think the people that the price, that take the training and the years out of their productive careers to go through 4 years of medical school, another 4 years of residency, and then maybe a 2 to 4 year fellowship. I mean, that commitment and the cost that goes along with it, essentially putting their futures on hold to receive that training and background. I believe it's not the kind of person that responds best in a traditional or typical employee role. And so it's been tough on them. And some of the loneliest people you'll find are physicians because they don't have a connection to a community. And so we want to provide that for physicians who would find benefit or find the ability to help them work their way through challenges, to be able to bounce things off of colleagues in a safe place. So our ProviderBay.com, it's a paid membership community. We make sure that that these are actual physicians that become members. We check the NPI number and kind of vet that out. But then they come into this online space in a safe and protected environment and can discuss real life, everyday challenges. And through the discussion forums inside the community, they can get help and offer help to other colleagues who are struggling. Execubay is very similar, but it's for senior leaders. Perhaps if there any more lonely profession in a community in a geographic area like southeastern Kentucky, perhaps the more lonely person is than even the doctor or the nurse practitioner is the hospital leader who can't even go home and talk about their workday in specifics because of the requirements for confidentiality and privacy. And it's just a very difficult time. And so we want to support the senior leaders and those preparing to be senior leaders, whether they're in MHA programs now or maybe in middle management roles, but hoping someday to hit that C-suite position or even a chief executive or the top senior leader role, to actually lead an organization, to support them in Execubay.com. We're going to do all that in a lot of different ways, but one of the chief ways we plan to get the word out is through our weekly podcast, the title Caring for Healthcare. We believe that's an appropriate title for what it is that is in our heart. I have a great team around me, the Adminologybay team, consists of a PhD, Kevin Flora, who understands social media and how to move the social conscience in a big way, in big numbers through all of the social media platforms. My son, Josh, from a technical standpoint, Josh Coppock is on our team. Mindy Bess, a nurse practitioner. She is a family practice or family medicine practice nurse practitioner working in our community. It happens to be our oldest daughter, and so just thrilled to have her on our team. Then we have just a wonderful HR professional helping us develop the cultural aspects as we move forward. So the whole idea is that we help leaders and providers sort out the challenges and that they face from a practical sense every day. We're not the academic place. We're not the place that's well, there's this theory and here's this set of core tenets, and here's this structure that we can offer. We are more practical, on the ground. Here's a problem I'm facing today. Have you ever encountered that before? And then to bring that to a forum, that question or that issue to a forum, to allow others to kind of help each other.
Alan Coppock, much luck with your new healthcare provider community as you begin to tackle some of healthcare's most pressing challenges. And thanks very much for sharing your perspectives today on the Hospital Finance Podcast.
It's been my honor and thrill.
If you enjoy the Hospital Finance Podcast, please head up to iTunes to subscribe and leave us a positive review.
This concludes today's episode of the Hospital Finance Podcast. For show notes and additional resources to help you protect and enhance revenue at your hospital, visit Bessler.com/podcasts. The Hospital Finance Podcast is a production of Bessler Consulting.